What's up, guys? Joel here with the Shift Brief. Today's episode, we're going to be talking about cardiac access. This is more of a nice to know for pre-hospital clinicians and not a need to know. It is something I find quite interesting, and there is a few practical uses. Once you're familiar with it, you can apply it. So let's get going, dig into it a little bit, and see where it takes us. To better understand cardiac access, first we need to look at the conduction system of the heart. The cardiac conduction system is the electrical network within the heart that allows for coordinated beating of the heart from the atria down to the ventricles, and then from the ventricles out to the system into the lungs. In the normal beating heart, it starts with the SA node, which is located in the right atrium up by the superior vena cava. It travels down to the AV node and is slightly slowed there, then down through the bundle of His, and then down through the right and left bundle branches and into the Purkinje fibers. The direction that this energy is traveling is known as the cardiac vector. So from the SA node down towards the Purkinje fibers, and from the patient's perspective, it has a downward and leftward direction, or downward and leftward vector. Now that we know what a cardiac vector is, we're going to look at how to apply it to an ECG. It's important to remember that when the electrical impulse is traveling towards a positive electrode, it is going to create a positive QRS on your ECG. For interpretation for this episode, we're going to use lead 1 and lead AVF. Looking at lead 1, we're going to be looking from the negative electrode on the right arm over towards the positive electrode on the left arm. Looking at lead AVF, is going to be from, once again, the negative electrode on the right arm down towards the positive electrode on the left leg. This is important information because, as we just discussed, normal cardiac access or normal cardiac vector travels from the top down and slightly leftward. So if we look at lead 1, which is traveling from right to left, and we look at lead AVF, which is traveling from the top down, we would expect to see positive QRS complexes in both of these leads as the energy travels down and to the left towards both of these electrodes or both of these leads. If the electrical impulse is traveling away from the positive electrode and towards the negative electrode, this is going to give you a negative QRS complex in that lead. So for example, in lead 1, if the impulse is traveling from left to right, away from the positive electrode, you will see a negatively deflected QRS complex in lead 1. The same theory can be applied to AVF. So if the impulse is traveling from the left leg up towards the right arm, you will have a negative QRS complex in lead AVF. Since we know that in lead 1 and lead AVF, these complexes should be both positive in normal axis, any variance from this can be considered axis deviation of some sort, whether it's left axis deviation, right axis deviation, or extreme axis deviation. Another way of determining cardiac access is by using the hexaxial reference system. This is a way of measuring the electrical axis of the heart using degrees. We know that normal vector is negative 30 to positive 90 degrees. The easiest way to find the value of your cardiac access is to simply read the cardiogram. Usually in the top left-hand corner, you'll find a series of values. In that series of values, you should find a box labeled QRS axis. That value should be between negative 30 to positive 90, and if it is, you have a normal cardiac access. Anything outside of that will be an axis deviation. Left axis deviation is going to be from your negative 30 to your negative 90 degrees. Right axis deviation is going to be from your positive 90 to your 180 degree mark. And then extreme axis deviation is going to be from 180 to negative 90 degrees. So to summarize all this, we know the electrical conduction system of the heart starts in the SA node and heads down in a inferior and leftward direction. This is the vector of the heart, and this is the normal vector of the heart. somewhere between -30 to +90. We know in order to achieve that, we can look at a cardiogram and look and lead one in AVF, and if they're both positive, then we know that we have a normal QRS axis. We know outside of that, anything else can either be a left axis deviation, a right axis deviation, or an extreme axis deviation. There are various things that can cause axis deviation: bundle branch blocks, STEMIs, pulmonary hypertension, pulmonary embolism, just to name a few. The one time I actually apply axis deviation or QRS axis or vector to a patient's presentation is when I'm faced with a wide complex tachycardia. This is more for my general interest than it is to actually say I'm going to change how I'm treating my patient clinically. We know if you're looking at a wide complex tachycardia and the patient is unstable, they have a pulse, then we're going to talk about synchronized cardioversion, maybe some antiarrhythmics. If they are in cardiac arrest, then it's obviously defibrillation. If your patient is sitting up and talking to you and you have the opportunity to obtain a 12-lead ECG, look at the QRS axis. Your suspicion of VTAC is supported by an extreme axis deviation. We know this because a normal QRS axis, as we described earlier, starts at the top of the heart, depolarizes downward and leftward. In VTAC, it is the opposite. We know that the electrical impulse originates in the ventricles, so you get this retrograde depolarization that can point your QRS vector towards the extreme axis deviation. Guys, I can't stress this enough. This is a nice to know. Do not let your patient deteriorate because you're looking at a cardiogram trying to determine if it's SVT with aberrancy, hyperkalemia, or VTAC. Make sure you are treating your patient according to your protocols, and you can come back and revisit that 12-lead cardiogram later and say, oh yeah, this is what it was, or look, there's that extreme axis deviation. Treat your patient first, let curiosity run away with you later. Thanks for taking the time to watch this video on cardiac axis and axis deviation. It's a pretty deep dive, deeper than I thought we were really going to get into, and so I hope you all found it very useful. Make sure that you go ahead and subscribe to the Shift Brief on YouTube. You can follow me on Instagram or Facebook or TikTok or anywhere that you can really find me. Throw some comments in the video. Let me know what you want to see, and we'll take it from there. Thanks again.